Hello, and welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. This year, starting in September, we changed our Grand Round Series to a webinar format, and we're making an effort this year to have presentations most weeks throughout the year, informed by our colleagues on 4 different advisory panels covering areas of education, clinical work, staff training, faculty development, and research, with recommendations and input from residents as well. Today's presentation is funded through the Ripley Fund. I wanted to acknowledge as well Semhar, a staff member who's working a lot on the Grand Round Series and helping with coordinating things, including helping to put together the new survey that we have out for the post-presentation evaluation. I'd like to encourage you to fill out the survey after today's presentation. I've been writing thank you letters to recent individuals who presented, and it's very helpful for me to have information to include in the letter about what everyone thought about the presentation. For now, I'll stop and hand it over to Dr. Amrita Bhatt, who will introduce today's speaker, Dr. Freeman.
Thanks, Joe. Hi, everyone. I'm Amrita Bhatt, and I'm thrilled to introduce our speaker for today, Dr. Marlene Freeman. Dr. Freeman is a professor of psychiatry at Harvard Medical School. She's the Associate Director of the Center for Women's Mental Health, the Abra Prentice Foundation Chair in Women's Mental Health, and the Medical Director of the Clinical Trials Network and Institute at Mass General Hospital. She's the Editor-in-Chief for the Journal of Clinical Psychiatry. She's on the board of directors of the American Society of Clinical Psychopharmacology and a fellow of the American College of Neuropsychopharmacology. Dr. Freeman completed medical school at Northwestern University Medical School, residency at the Harvard Longwood Psychiatry Residency Program, and a research fellowship in biological psychiatry at the University of Cincinnati College of Medicine. Dr. Freeman's research, clinical, and teaching activities have contributed to the area of the broader practice of psychiatry and to women's mental health specifically. And she's published on integrative treatments for perinatal depression, risk-benefit assessments for use of psychiatric medications during pregnancy and breastfeeding, and infertility and risk for psychiatric disorders. I could go on, but let me end by saying that on a personal note, Dr. Freeman's work has helped guide my clinical decision-making in treating perinatal patients over the years. I've also, when I've been able to join, greatly enjoyed the virtual grand rounds from the Center for Women Mental Health that Dr. Freeman and Cohen opened up to the community during the pandemic. So with that, let me turn it over to Dr. Freeman.
Thank you so much for the kind words and the invitation to present today. So hopefully the technology will work for me here. Can you see the slides? Okay. So this is not where I wanted to be. So let me figure out how to get to my, let me get to the beginning. Okay, take 2. So again, thank you so much for having me, and thanks in advance for the interest in the topic. So we're going to be talking about perinatal mood disorders. This is my disclosure, mostly research through Mass General. So, you know, the topic of perinatal psychiatry really applies, you know, very broadly to clinicians. Like, as long as clinicians treat women of reproductive potential and girls before they even get to that age, then really perinatal psychiatry is a very important topic, because many of the disorders we treat, as you know, are chronic or recurrent. And so many women will come to the reproductive years already having had a diagnosis and started on medication, and many women will need medication throughout the reproductive years. So it's important to keep in mind from the very beginning of treatment that a patient that we may see may someday want to become pregnant. And we really want to keep that in mind. I think one of the most important points I could possibly make is that about half of pregnancies in the US are unplanned. So that means that even if a woman is saying, I absolutely 100% do not want to become pregnant, there's actually a great chance that she's going to become pregnant during the course of her treatment. But the other aspect of that is too, is that for many women, they wish to be parents, they wish to become mothers, and they may not be in a place to do that while they have a psychiatric disorder that's untreated or undertreated. But when they're well and living the lives they want to be leading, we really want to make sure that their treatment is compatible with pregnancy and being postpartum. So, it's really imperative as we think about risks and benefits of all treatments and risks and benefits of medications that we're thinking about reproductive safety of medications from the very beginning. And we want to think about all the things that really would contribute towards a healthy pregnancy. And most of these also are just, good practice in terms of general health. But, the jury is really out whether or not healthy adults need to take a multivitamin. But I would say for women of reproductive potential, women of reproductive age, it would make a lot of sense to just generally recommend that they take a multivitamin. And it's an easy recommendation to make, so to make sure that women get the amount of folic acid that is recommended in general. So if they're planning pregnancy, they can take a prenatal vitamin or extra folic acid. But if they're not planning pregnancy, then just being on a multivitamin or taking folic acid is a good thing in case of unplanned pregnancy. So it's one of, I think a big game changer that the more we learn about folic acid, the more important it is not only to prevent birth defects, but also in terms of neurodevelopment and possibly the prevention of some psychiatric disorders. So also easier said than done. We want to encourage patients to maintain a healthy weight, good nutrition. We know that patients with psychiatric disorders are at a higher risk for obesity, but it's something that as psychiatrists, we can really make sure is at the forefront of our treatment plans, and also encouraging exercise. We want patients to quit smoking if they're smoking, abstain from alcohol and drugs during pregnancy. We are seeing in Massachusetts, we are seeing just an incredible rise in the number of women that are using marijuana regularly, which has become sort of a subtopic on its own. So in all our consultations, since it's legally, legal here for recreational and medical use, the landscape has really changed on how patients perceive it. So, of course, we want patients to abstain from illegal or illicit drugs, but we also separately want to be inquiring about marijuana and alcohol. It's really important from a perspective of perinatal mental health that there's good communication across providers, because this is an area where there's a lot of misinformation or, really sort of like complex understanding needed to convey information to women. And so it's really anxiety provoking when a woman has made a decision, say, to stay on a medicine during pregnancy, but then she hears from different healthcare providers that she definitely should not be on that medicine during pregnancy, from another provider that she should be. It really provokes a lot of anxiety around it. And some of the information is, hard to stay up to date with. So it's really important that as psychiatrists, we are in good communication across specialties. And then if a woman is not planning pregnancy, it's really important to check in about what she's doing to prevent pregnancy. So as we would update lists of medication, like at every visit, to ask about what someone is doing for contraception if they're not planning pregnancy. And it's kind of surprising sometimes, even among patients that are extremely educated, sometimes they say that they're not trying to get pregnant, but they're also not doing anything to prevent it either. So it's really important to talk about that topic with patients. Now, I think one of the sort of the major challenges and how we spend a lot of our time in perinatal psychiatry is really assessing the context for risk. So thinking about all the confounding variables. So in general, the rate of major malformations in this country is about 3%. So according to CDC data, and that's substantial. That affects a lot of pregnancies. The rate of prematurity, which leads to a lot of morbidity and mortality among babies, is about 11 to 12%. And there are certain segments of our population, particularly more socioeconomically disadvantaged groups, that are at higher risk. The rate of gestational diabetes may actually be underestimated here, between 2 and 7%. And importantly, untreated psychiatric disorders carry risk. So every psychiatric disorder that's been looked at has been associated with an increased risk of obstetrical complications for the most part. So, being unwell is not good for pregnancy. And of course, we want to talk about substances, but for many of our patients who have comorbidities with substance misuse disorders and other disorders, treating the comorbid disorders is crucial in terms of them being able to abstain from use of substances that would be problematic. Importantly, obesity increases the risk of major malformations, so birth defects, and also many obstetrical and neonatal complications. And so many of the studies that you'll see in perinatal psychiatry don't control for many of these factors and don't control for obesity. So, that's why, each study that you may come across really needs to be judged for its limitations, strengths and limitations, but often limitations. So for example, some of the risks of untreated depression may negatively affect eating, sleeping, self-care. Some women won't fully engage in prenatal care if they're depressed. It's thought not only with depression, but across disorders that the physiologic stress of having an untreated disorder like depression or anxiety disorders increases the risk not only of obstetrical and neonatal complications, but also potentially long-term sort of programming for the infant, like beyond infancy through childhood, and could affect the child for life. So we really, again, want to emphasize to women that there may be several options for treatment, but we really want wellness to be the goal. And with anxiety also, because we see so many women with anxiety disorders during pregnancy, we know that untreated anxiety is associated with more complications, and there may be longer term impacts as well. So up until recently, the FDA had a lettering system for all the package inserts of medication. So categories, A, B, C, D, X. And they were widely used, widely looked up by healthcare providers, by patients. And I would say that they were user-friendly in that they were letters and they seemed straightforward, yet they were, I would say, seductively oversimplified. So they were misleading at best. So most psychotropic medications were labeled C or D. A few were B, and none of them that were actually labeled B actually deserved it based on human systematic data. So what would happen is if a new drug came to market, it would come in front of the FDA. And at that point, generally, there would be zero human systematic pregnancy data. So zero human data for pregnancy outcomes, and a letter would still be assigned based on a small amount of animal data. And it was really crude. So they would look at some rabbits or rats, no problems. Well, then it might be category B. And for older medicines that might be very appropriate for use for some women first line, they might have been category C or D, particularly D if anything negative had ever been associated, even if cause and effect had not been established. So it was misleading because for some women, their best medicine, the most appropriate one might have been category D. So it would scare people. And then category B, all the medicines that had been category B, not one of them had human systematic data at the time the B was assigned. So again, it was incredibly misleading. So a few years ago, the FDA got rid of the letter grades. New medications no longer receive them, and they're being phased out of older medications. So they're really not being assigned at all anymore, but there's still a carryover because healthcare providers remember what some of these were assigned. But right now, there's a new system, and it's like sort of careful what you wish for because it's not as simple, but it's more precise. So what we have now in the labeling are subsections. So this is the pregnancy and lactation labeling rule, or it was called the final rule. And what you see in the package inserts are subsections with pregnancy first, with human pregnancy data prioritized over animal data, then lactation data, and then other reproductive considerations. And if there's a pregnancy registry, that would go first under human data. And then if there's a summary of human pregnancy data next. So for some medications, there really is not much to say. There has not been much in terms of studies. And for some, there's been quite a lot. So it's challenging to really summarize that. What's so important about that is that it's not written at a patient level. So it's written at a healthcare provider level. So it's really can be confusing for patients. So it's not like a informed consent document where it's written for patient understanding. And then also what would be in that section would be, other information, animal data, etc. But what's also really important about these new labels is that a context is provided. So remember, the baseline rate of major malformations is about 3%. Pregnancy itself is inherently risky. So if we report a problem with a medication, we want to know at the very least what the background population rate of that problem is so that we can make an appropriate comparison. But even better, if we could compare it with women who have the same disorder, but are not exposed to that medication, that gives us a better sense of, really trying to control for some of the confounding variables that go along with the illnesses themselves. So years ago, the American Psychiatric Association and American Congress of Obstetricians and Gynecologists came out with some joint recommendations that are still very relevant. So they recommended that for more mild depression, psychotherapy is first line. And it's hard really to conceptualize any situation, regardless of severity, where psychotherapy would not be part of the plan. So we're always recommending psychotherapy to patients. We want to be talking about those lifestyle components like nutrition, weight management. We want to document any substance use. And for women who are trying to conceive, we want to encourage them to have a period of wellness if they're not well before they conceive, but that can get kind of tricky depending on a woman's age. So if she's older, she might have less time that she can really wait, regarding her fertility. In pregnant women with moderate to severe depression, medication is absolutely considered first line, and we'll talk about more of the specifics. We want to pick medication based on reproductive safety data that's known, and that's, again, for women, even if they're not planning pregnancy. So I want to just highlight some of the big controversies and give you an overview, but I can't possibly cover them all. So I want to refer you to our website, which is www.womensmentalhealth.org. And because the literature is constantly changing in this area and can be complicated and hard to stay on top of, we have a blog that comes out, which is basically a research summary, usually weekly. But if there's a hot controversial topic, especially one that's worrying patients or clinicians, we try and get something up as quickly as possible. And there's also a search tool. So if you're wanting to ask a question about a specific medication, you can search the website. So SSRI use during pregnancy. SSRIs are very commonly used during pregnancy. Up to 10% of women are on antidepressants during pregnancy, with SSRIs being the most common used. And overall, when you take it all together, the data are overall reassuring with regard to reproductive safety. So overall, SSRIs do not appear to be teratogenic. They do not appear to be associated with birth defects. There have been actually so many studies at this point that if you go through the literature, you can find some concerning studies, but taken together, there does not appear in the most rigorously done studies to be an association between SSRIs and birth defects. And we really know so much more about SSRIs than most medications, really across fields of medicine that are used in pregnancy. Now, there had been a lot of concern generated specifically about paroxetine about 15 years ago now, whether it was associated with an increased risk of cardiovascular malformations. And the concern had been raised also with some other medicines as well, but paroxetine being sort of the most notorious for this. So remember that, really taking into account the confounding variables is sort of the key to perinatal psychiatry to know really, is there an association or not? And so a really well done study from the Harvard School of Public Health looked at this more recently using a really large Medicaid database. And they specifically looked at cardiovascular malformations and tried to take into account all the variables that would affect it. So they looked at a large number of pregnant women in a database. They looked at SSRIs, and then they looked at cardiac defects, and also then controlled for various factors. So what they saw, if you look, if the dotted line basically means, if the bar crosses the dotted line, that there's no significant increased risk. And this, from the raw data, it looks like most antidepressants are not associated with an increased risk of major malformations specifically. But when you control for having depression, there's even less of an effect. And when you control for other variables associated with depression, even less. So, it really does, I show the graphs just to show how there appears to be less and less of a risk when you control for the variables that are known to go along with depression that could increase the risk of poor outcomes. So another question that's been raised, and now we have so many studies, we have meta reviews of meta-analyses, is whether or not antidepressants are associated with the risk of autism. And this was a very serious concern raised years ago, because of course, if antidepressants were associated with an increased risk of autism, that would require some very serious attention. But as data have come in and there have been more controlling for variables like genetics, family history, and all the variables that would factor in, it looks like, at least when you control for maternal mental illness, there is not an increased risk of autism. So it is true that if you look at women on an antidepressant versus not on an antidepressant, there may be an increased association, but it does not appear to be due to the antidepressant itself. It appears to be due to the confounding variables. And that's so true of so much of the work we do, is looking at, how comparable are the two groups? So women on a medicine versus women not on a medicine, like what else is different between those two groups in addition to the medicine? So another question had been raised about whether antidepressants, particularly in later pregnancy, was associated with a serious lung condition called persistent pulmonary hypertension of the newborn. And this is, again, an area where there had been great concern when the question was first raised. The first study showed about a 1% risk that looked at this, but importantly, it did not control for many of the factors that are known to be associated with an increased rate of this. And other studies that came out subsequently did not show an increased risk. And again, this is a study from the Harvard School of Public Health that has done a lot of these large analyses looking at a large Medicaid database. When you look at the absolute risk, where there wasn't a significant difference, with the baseline population, it was 0.2% risk of this condition and 0.3% with the antidepressant. So, so taking into account the baseline rate of a problem is really important, because this was not a significant difference. So this is something that we don't think is a true association with the medicine. Now, one of the things that I think is very plausible, and I spend a lot of time talking with patients about this, is whether or not there's an association with a neonatal syndrome after a mom is on antidepressants in pregnancy. So it's been, reported that up to a quarter of babies may have either what's been called a withdrawal, or we have no evidence that it's a withdrawal, or some syndrome that we usually refer to as poor neonatal adaptation after a mom's been on an antidepressant. And so what's most commonly reported is some fussiness or jitteriness. In the literature, almost every medical problem has potentially been reported in cases to be associated with medicine use. But I do think it's plausible that babies are born, if the mom's on the medicine, they have a little medicine in their system, and they could have some adverse effects as they're metabolizing it out. But the reason I spend so much time with patients on this topic is not because I'm so worried about something actually occurring because of the antidepressant use, because no one did any study leading up to it, but all the package inserts were changed because of this concern with no research done whatsoever. No research, and all the package inserts included a statement saying women should seriously consider stopping antidepressants in the third trimester. So I think the perinatal psychiatry community was pretty much unanimous in disagreeing with that recommendation, because the women who would be on medicine in the first place would be the ones at highest risk of postpartum illness. And the last thing we want to do is send a woman home from the hospital unwell. So, relapsing with a depressive or an anxiety disorder. So we've never practiced that. We've never done that. And since then, the only reports that try and rigorously study this don't support that that the antidepressant is clearly associated with neonatal symptoms. So there have been reports that exposure, each trimester individually is associated with an increased risk of neonatal symptoms, which means possibly it's the underlying disorder. Probably could be the underlying disorder, and also that obstetrical complications seem to greatly override the risk of medication. So, for example, our colleagues led by Kathy Wisner at Northwestern did a study looking at women on an antidepressant with depression compared to women with depression not on an antidepressant, and then healthy controls all through pregnancy. And there was actually no difference in outcome in terms of neonatal, observed effects. But really the driving factor in neonatal symptoms was prematurity. So it really underscores, that, having a healthy pregnancy is the most important thing with regard to this concern. Now, the reason that I spend a lot of time talking about it with patients is it's almost routine now that when a woman is in the hospital for her labor and delivery, and she's so vulnerable, and we've talked about this in, I always include partners in this discussion, pre-delivery, is that, many women have come back just so shaken by having had a healthcare provider say, don't you know you were supposed to stop taking that in the third trimester? Or if there's any problem with the baby, that a healthcare provider will say, this happened because you were on the antidepressant. So we really want to buffer women from that, because they often feel so guilty or so judged. And it's so, it's generally so counter to the advice that we're giving them. But there's so much misinformation out there on this topic. And so if healthcare providers don't specialize in this topic, they might not know how confusing this is. And patients may get, very mixed messages about this topic. But we tell patients, in almost every scenario, to stay on the medicine because of the risk of postpartum illness, which can occur very rapidly after delivery and can be very severe. Bupropion in pregnancy is a medication that we've learned a lot more about. It was one of the medications studied in that recent large Medicaid database study. At one time, there had been a concern whether or not there was an increased risk of major malformations. But at this point, it doesn't actually appear that there is. So we do know that stopping a medication that is working for someone is associated with an increased risk of relapse. So pregnancy itself may be risk neutral, but stopping a maintenance medication is associated with an increased risk. And we see that with major depressive disorder, and we see it even more prominently in bipolar disorder, which we'll get to. Now, when we're talking about postpartum disorders, we're really talking about several, different topics. And many women will have some confusion about what's the postpartum blues and what's postpartum depression. So the postpartum blues is not actually a disorder. It affects the majority of women. It's transient, it's mild, but many women will report feeling, somewhat sad or quote unquote hormonal or tearful, and not really know why. They also may be exhausted, which is, pretty par for the course. But we want to keep a close eye on it to make sure it's not the beginning of a depressive episode, but what we call postpartum depression is the real deal. So a major depressive episode that occurs in the postpartum. And there's probably more debate about this than you would think about what we call postpartum depression. So, the advocacy community would like a lot more of a broad definition, like going out further in the postpartum. DSM-5 limits it to onset within 4 weeks of delivery. But basically, postpartum depression, what patients really want us to understand is the context. So there's a lot of heterogeneity, but but patients really, I think, prefer that it's called postpartum depression rather than a major depressive episode, because they really want the context of caring for a new baby and maybe breastfeeding conveyed along with the diagnosis. Postpartum psychosis we'll talk about, and also some special considerations for women with bipolar disorder. So postpartum depression has been called the most common obstetrical complication, affects between 10 and 15% of new moms, up to 25% in women who are specifically in higher risk groups. One of the biggest factors with postpartum depression is comorbid anxiety. So depression and anxiety are often comorbid, but they're especially comorbid in postpartum depression. And that often manifests in terms of obsessive thoughts. So many women will have incredibly distressing obsessions. Now, there are a few areas of psychiatry, psychology that we know so much about as the negative impact of maternal depression and postpartum depression on child development. So that's why it's so important that it's identified and treated. But it's tough because a lot of women feel guilty, taking time and resources to engage in treatment for postpartum depression. And what we really want to ally with women around is that it's not only good for themselves, taking good care of themselves is taking good care of their baby and their other children, if there are other children at home, because the impact is so great. Now, breastfeeding. So breastfeeding is the topic that by far, I've seen more tears shed in my office than any other topic. So breastfeeding in a perfect world, all women would breastfeed. So, from a nutritional standpoint, breastfeeding is best. I'm just going to put that out there. I'm not arguing with that at all. But what we have to keep in mind that it's, not one prescription for everyone. So breastfeeding from a nutritional standpoint is important, but it's also very difficult for many women. And that's why we have a whole class of healthcare providers, lactation consultants. So for those of you who don't have children, newborn babies, it's lucky they're cute because they're like slave drivers. Newborn babies need to eat like every 1 or 2 hours, and then they're up for a while and then they go back to sleep, but they're like whole cycle is every 1 or 2 hours. So like the most consecutive sleep the new mom, if she's exclusively breastfeeding from the breast, can hope for is like a couple hours in a row, maybe 3 hours if she's lucky. And we know that for many women, especially those with mood and anxiety disorders, getting some consecutive sleep at night can make all the difference between being well or being very sick. So we really want to talk to women during pregnancy with their partners or other family members about how to plan ahead for sleep and feeding. So in general, there's a lot of pressure on women to breastfeed these days. So, hospitals get this designation about being baby friendly, which basically is a lot of pressure on women to breastfeed. And again, I'm not arguing with the concept of breastfeeding, but women often feel very judged and very pressured, and it's just not for everyone. But we generally recommend that women introduce bottles from the very beginning, and that's contrary to the advice that women are generally given. They're told don't introduce bottles because the baby will get nipple confusion. And I will say, if a woman has a serious psychiatric disorder, nipple confusion doesn't make the top 10 list of things that she should worry about in the postpartum. So we encourage all women to introduce bottles in their feeding regimens. Could be pump milk, could be formula. A lot of women sort of feel like they need permission to introduce formula because of the pressure and the judgment that women often get, but that allows for someone else to do some of the feeding so that the woman can get more sleep and spend more time on self-care. And oftentimes we see this bidirectional relationship between women who are unwell psychiatrically and difficulty breastfeeding, where the difficulty breastfeeding makes them feel worse. It can interfere with the psychological transition to becoming a new parent. And it can be really rough. So sometimes patients really do need to hear from us that it's absolutely okay not to breastfeed, or it's okay to do a combination of formula. And really, it's kind of amazing how emotional this topic can be. So in terms of treatment recommendations for women who are pregnant or breastfeeding, we definitely want to talk about the role of medications, their first-line treatments. We always want to use the lowest effective doses, but we don't want to undertreat. We want remission to be the goal. And it's a time that if healthcare providers are uncomfortable, it's time to really consult with experts. And I was just hearing before the grand rounds that in your state, you have some supports for healthcare providers on the front lines to get, backup support with consultation. And we want to maximize the non-medication treatments. So in terms of treatments and antidepressants for postpartum depression, there haven't been that many controlled trials, but we can assume that antidepressants work similarly for postpartum depression as for major depression that occurs other times of life. We just want to keep in mind the comorbid anxiety, and so serotonergic antidepressants like SSRIs are a very good fit for many women. Now, if a woman is trying to abstain from smoking, quit smoking, or remain free from smoking, then bupropion may play a particular role for her as well. So some of the caveats, the way we have good information about using antidepressants during pregnancy is that mom-baby pairs have been in studies where the amount of breast milk is actually measured that gets through to breast milk into baby's blood levels. The way we have bad information in my information are case reports of N equals 1 baby, where there might be a reported adverse effect that we would never know is due to the medicine or not. So for example, there had been a case report, N equals 1 baby who had quote unquote sleep difficulty when the mom was using citalopram, which resolved when the baby was months older and the mom was no longer on the medicine, which is a goofy case report because babies start consolidating sleep more as they get older anyways. So fluoxetine is known, it has a long half-life, so it's known to at higher doses to be detectable in infant blood levels. It is absolutely compatible with breastfeeding. So if fluoxetine is a woman's best antidepressant, or especially if she was on fluoxetine during pregnancy, that would be the one that we would either stay with or restart. Sertraline is one of the medicines that has the most mom-baby pairs in the literature. So does paroxetine in terms of a lot of mom-baby pairs with no adverse events, usually non-detectable, but sertraline tends to be better tolerated. So if a woman has never been on an antidepressant before, that's often one that's recommended to start. But antidepressants as a class are considered compatible with breastfeeding. We just know more about some than others. And for some of the newest ones, we don't have any information. But again, as a class, we would consider them compatible. And if a woman has had a really treatment refractory course of illness, then it's more justifiable both during pregnancy and breastfeeding to use a medicine that's less well known. So some of the other treatments, of course, psychotherapy, that's the number one go-to non-medication treatment we're always recommending. For women with very severe illness, ECT is an important consideration both during pregnancy and postpartum. And we often get a lot of interest in complementary and alternative treatments. And I just want to mention these briefly, but for most of these treatments, I would say, we want to be careful because it's often attractive for patients to try something natural. It's often assumed that something natural is better or safer, but I think we need to hold, especially like nutraceuticals, something that would be taken like over the counter. We want to hold those to the same, with the same rigor as we would hold a prescription medication in terms of wanting data for safety and efficacy. And for most of the supplements that women take, we absolutely do not have that. So some of the things that have been looked at, omega-3 fatty acids have been looked at. And most of their sort of claim to fame in psychiatry is augmentation of antidepressants. So we could consider that reasonable as add-on. We're always talking about exercise, which is important for healthy pregnancy as well. Folate, Folic acid, most women are already supplemented with folic acid, and it doesn't appear to be protective specifically in the perinatal period. There's a little bit of data specifically in the postpartum with S-adenosyl L-methionine, which is SAMe, but not during pregnancy. It's related to folic acid. St. John's wort, because it's natural, should not be considered safe. It's just much less well known than antidepressants. And then some other treatments that women sometimes pursue, and usually as add-on treatments, where there's some literature to back them up, are acupuncture, bright light therapy, and massage. Also just wanted to briefly touch on Brexanolone, which was FDA approved in 2019 for the treatment specifically of postpartum depression. So it was exciting that the FDA recognized specifically postpartum depression as an indication. It does appear based on clinical trials that it's more effective than placebo in the studies that were done. However, it has to be delivered IV, and it has to be delivered over 4 days in a hospital setting or an infusion setting. So it's not something that's clinically available to most women. It's also very expensive. But it's a new class of medicine, so neuroactive steroids, and there are PO alternatives that are being studied right now in phase 3, which is also very exciting, not only for postpartum depression, but also for major depressive disorder in men and women. So we'll be hearing more about those, I think, in the near future. I want to shift gears and touch on bipolar disorder across pregnancy and postpartum. As I mentioned before, there is an increased risk with medication discontinuation. So, makes sense in general with bipolar disorder. Stopping a mood stabilizer that's working for someone is associated with relapse, and that's true in pregnancy as well. And it appears to be, though, of all times of life, the time that is most exquisitely vulnerable in the lifetime of a woman with bipolar illness is the postpartum. So the risk of severe illness in the postpartum appears to be especially high in women with bipolar disorder. And we can see that from data regarding hospitalization. So psychiatric hospitalizations really peak in the postpartum, and that generally represents women who have bipolar disorder or women with postpartum psychosis. And the majority of women with postpartum psychosis actually have that in the context of having a bipolar diagnosis. So speaking of postpartum psychosis, it's generally discussed as a rare disorder, but it's really not that rare. So, 1 to 2 out of 1,000 pregnancies, considering, how many pregnancies there are just in the US alone every year, that's a lot of women who develop this illness. And so it can be very dramatic, seen within the first few weeks, or it can occur later, less commonly. There's a very high risk of harm to the self and for suicide and harm to the infant. And it's a very recurrent disorder. So if women have had postpartum psychosis, they're at great risk of having it again. It's like up to 80% of women will have it after a subsequent pregnancy. And so we see women who've had it before and they're planning ahead for next pregnancies. And so it's really important that when we talk to women about planning ahead, that they understand how recurrent it is, but also that partners or other family members are part of the discussion to receive psychoeducation around this, because there is such a great risk of harm. So these are the really, big tragedies we hear about where an infant or children are killed. And it's actually, it's difficult to even say that out loud. In a grand round setting, but it's also very difficult to talk about with patients, but they need to know, because it's so important to prevent future episodes, which they can do by restarting medicine if they stop for pregnancy. Now, the diagnosis that's most associated with postpartum psychosis is bipolar disorder. And it's considered an emergency in all cases. We want to send the woman for urgent evaluation for hospitalization. So thoughts of harming the infant can be confusing for some providers on the front lines, because it's very common for patients to have OCD symptoms in the postpartum, or postpartum psychosis. So the biggest difference is really insight. So women with postpartum obsessions might have, intrusive, distressing, disturbing thoughts that they can't stop having, but they're disturbing. They don't go along with their typical thinking, and they're bizarre to women. So they may be, for example, afraid to cook, because I had one patient tell me she was afraid to pick up a knife because she was afraid that she might inadvertently have the knife, fly out of her hand and stab the baby. So she knew this didn't really fit reality, that it was not likely to happen, but she couldn't stop visualizing that. So that's very common as a postpartum obsession. With postpartum psychosis, what we often see are religious delusions, where women may actually be thinking about harming the baby in a way that might be considered more consistent with their psychosis, like that maybe thinking that they're going to save the baby by killing the baby. So it's, sort of totally different sort of context for those kind of thoughts, but healthcare providers may hear those kind of thoughts and really need to differentiate those. So postpartum psychosis is incredibly dangerous. Postpartum OCD or obsessions is not. So with mood stabilizers in pregnancy, so lithium is actually known to be a teratogen. It's known to increase the risk of cardiovascular malformations, and is most, long known for an increased risk of a rare disorder called Epstein's anomaly. But what's important is that the absolute risk with lithium is still low. So for women who are lithium responders, it may make a lot of sense to continue lithium throughout a pregnancy, including the first trimester when heart formation occurs. So I think more and more as a group in our at Mass General, we're more hesitant than ever to take women off of mood stabilizers for pregnancy, including lithium, because we see that sometimes even with just small changes in their regimen, women often become very ill and ill for long periods of time. So if women are doing well on lithium, it is absolutely reasonable to leave them on lithium and discuss this as a potential risk. If women are on lithium during pregnancy, then we often recommend fetal echocardiography to image and the heart and function during the pregnancy. But I've had a lot of patients stay on lithium during pregnancy, and I have not seen a bad outcome with that. It's uncommon that there would be a bad outcome. And as you know, the mood stabilizers are not interchangeable. So women who do well on lithium may not do well on something else. Another important thing to know with lithium is that it's excreted more rapidly in late pregnancy. So it's not uncommon that women would need a higher dose in latter pregnancy. Valproic acid is the worst teratogen known to psychiatry, and we should forget it exists for women of reproductive potential. So for girls and women until they've had hysterectomies or they're postmenopausal should not be in the same room as valproic acid. It is bad stuff. So most risk of major malformations occur before women even know they're pregnant and they're serious. So neural tube defects like spina bifida, brain development is affected by valproic acid. The more we learn about valproic acid, the uglier it looks. So it's a high risk of birth defects. It's a high risk of poor neurodevelopment with lifelong outcomes for children in terms of neurodevelopment. So we don't just want to stop it in the first trimester and then restart it because it looks bad later too. So valproic acid, not on the table. So again, we really want to forget it exists. And fortunately, we have a lot more options today than we did a couple decades ago in terms of mood stabilization. So when we look at kids that have been followed, our neurology colleagues have done a great job keeping anti-epileptic drug registries during pregnancy. And then they've looked at neurodevelopmental outcomes in kids. Kids exposed to valproic acid do more poorly on neurocognitive testing at age 3, and it looks the same at age 6. If you look, though, in comparison at lamotrigine, the more we learn about lamotrigine, the better it looks. So with lamotrigine in pregnancy, initially when it first came out, it had been reported that it might be associated with an increased risk of oral clefting or cleft palate. As more numbers became available in those studies, it appears that lamotrigine is not associated with any type of birth defect. It's also cleared more rapidly during pregnancy, so women should be monitored closely for clinical symptoms and may need dose increases, but you still have to follow the recommendations of the slow titration. Now with atypical antipsychotics, we're learning more and more about these all the time. We have a registry at Mass General, and if you have patients who are pregnant on these, we'd be grateful if you'd refer. There was recently a large administrative Medicaid database by the colleagues that I mentioned earlier at the Harvard School of Public Health that did not show an increased risk of major malformations with the class as a whole, or with most of the individual atypicals, although they did see a slight risk of major malformations with risperidone in particular, and it's not clear why. Most studies have not controlled for a lot of the confounding variables, which is why we keep our pregnancy registry, so we can have controls who also have psychiatric illness and prospectively collect all the information about confounding variables. We've published on this and have another paper in press with greater numbers, but in general, what we're seeing from our prospective pregnancy registry is that as a class, we're not seeing an increased risk of major malformations. We're at a point now where we're starting to be able to report upon some of the individual medications. We've published specifically on quetiapine, and so far do not see an increased risk of major malformations. And within the next year, we'll be publishing on some of the other atypicals. So overall, as a class, the data are reassuring. Now, breastfeeding, just want to mention that of the medications that we use in bipolar disorder, some are better known than others. For some of the atypicals, for example, we have very little information. With lithium, there have been enough case reports of adverse events and high blood levels in babies that there's enough concern that we generally recommend women do not breastfeed while they're using lithium. And that's the only medication where we really discourage women from breastfeeding. When it's a case of a medicine that's less known, then we really try and make collaborative decisions with women based on what they want to do. But the first and foremost, we want to make sure that they stay well. But just because a medicine is not very well known, it does not mean that breastfeeding would be contraindicated. But for the most part, lithium is discouraged in breastfeeding. There had been one study to look at mom-baby pairs and to assess under what conditions it might be okay. And in general, the recommendations from that one study was that, if the woman was on a simple regimen and doing well, the baby was full term and healthy, and the pediatrician was on board and could help adhere to really careful monitoring, that it might be okay. I still discourage patients from breastfeeding on lithium. I have had a handful of patients on low dose lithium breastfeed successfully, though, with the pediatrician being strongly supportive. But in most cases, we do not have women breastfeed on lithium. Now, we don't have them switch. So if their best mood stabilizer is lithium, they were on it in pregnancy. Instead, we talk to them about not breastfeeding, but not stopping the lithium because the postpartum is such a high risk time for relapse. So at this point, I'll stop because we have a few minutes for some questions, and I really appreciate your time and focus on this topic today.
Thank you, Dr. Freeman. I want to get right to the questions. One came in asking what you had commented on about lithium, but in general, are there studies about changes in metabolism comparing the pre-pregnancy, during pregnancy, post-pregnancy periods?
Changes in metabolism of medication?
Yes, correct.
So specifically, we see that with lithium and lamotrigine. And we know that women will have declining blood levels of both those drugs, especially later in pregnancy. And there is some controversy about what to do about it. So in our program, what we do is we just keep in mind that women will metabolize those medicines more rapidly. And we have a low threshold based on clinical symptoms to increase the dose. We don't check blood levels and prophylactically increase the dose if the woman is doing like fine clinically, because we don't want women on more medicine than they need to be on. But I know at other centers that specialize in perinatal psychiatry that they do. So there hasn't really been a study showing that the therapeutic drug monitoring and preventatively increasing the dose is better than careful monitoring. So not everyone has the same practice in that area. With antidepressants, it's more variable. I would just keep in mind that in late pregnancy, some women might metabolize medications more rapidly. It's more common with tricyclics than it is with SSRIs.
Thank you. Two questions came in about, I think, maybe wanting to push some about valproate and wondering if there's ever a context, like in the context of a woman having an IUD in place, would that be a potential consideration?
So, I really wouldn't, because here's the tough thing is that if the woman is stabilized on valproic acid, and then she decides she wants to have a family, or she gets the IUD out and then it inadvertently becomes pregnant, then you're like in a very bad place. So at best, you don't know what mood stabilizer to put her on when you take her off the valproic acid, but also the insult of valproic acid is so incredibly serious. Some European countries have actually contraindicated it in women of reproductive years. So again, I would say off the table.
Thank you.
Black and white.
Is there, how often do you check in your practice? Do you check lithium serum concentrations during pregnancy?
So, not that often. So I always check as according to, I think the APA guidelines are at least, each quarter for the first year, and then with any dose changes. I might check once a trimester. I try not to send women in specifically for blood draws for lithium only. I'm actually, we're seeing a lot more women on combination regimens, so not just lithium monotherapy. So they're often getting by with 900 milligrams or less, where they're unlikely to have toxic or high blood levels where we would check more frequently. So I'm mostly sending them to the lab for thyroid function tests and the renal panel, or other labs too. And so I get a lithium level when I do that, but usually not more than once a trimester at most, and then sometime in the postpartum. So we don't follow it generally as rigorously as some other places where they might increase it preventatively.
Thank you. Complicated question. Are there studies about whether, I'll broaden this question some, treatment of psychiatric disorders in general, or specifically a treatment with medications, can mitigate risk of intergenerational transmission of psychiatric disorders?
Yes. So, the best example, I think, comes from the STAR-D study, where moms with depression were treated and children were followed. And treating the mom and not treating the kid, just treating the mom and monitoring children, show that if you treat women to remission, that children experience fewer psychiatric symptoms and diagnosable disorders based on the mom's remission. If the moms were remitted, the children did better. Well, I think, though, if the question is, if you treat the woman during pregnancy, does the kid have better outcomes for a lifetime in terms of psychiatric disorders? I think that that's under study, but I think that probably the answer to that is yes. But I think we know that more from like models of toxic stress than we do specifically from specific disorders. So but I think what's important is what often gets blamed in terms of child and adolescent psychiatric illness on medication exposures that occurred long ago in utero is that if a woman has a disorder serious enough to treat during pregnancy, she probably experiences some illness during that child's childhood, which we know is very important in terms of child development and psychiatric symptoms in children. So that's important to keep in mind when you're looking at studies of 15-year-olds, that it's very likely the mom was depressed during the childhood, and that has to be factored in.
Thank you. With the final 1 or 2 minutes, not an easy area to get into with limited time, but what's happening with current studies in cannabis during pregnancy?
The more we learn, the worse it looks. So it's surprising. So especially younger moms are using a lot of cannabis, often daily during pregnancy. They assume it's safe. So something like a third of younger pregnant women are using cannabis regularly. They often don't really think about it as a potential exposure. But as we learn more about pregnancy complications and neurodevelopment, it does look like it has negative effects, and that's on our website if people are more interested in that. But it's a very important topic, and it's important that we ask about it because I think patients don't even think sometimes to tell us about it.
Well, thank you very much, Dr. Freeman, for your presentation today. So many important points. And the amount of expertise that you shared with us today, I think, has informed many of us. We've generated questions based on your presentation. I thank you very much for sharing your time with us today.
It's my pleasure. Thank you for having me.
All right, and we've got your website that we'll take a look at that Mike put up in the chat. And thank you, everyone, for joining us today.
All right, take care. Stay well. Happy holidays.
Same to you. Bye.